A very good evening to all. At the outset, I would like to thank AIS and Vinod Arora sir for having me here. It's been almost a lot of, I think, 3 or 4 years I have been a part of this course. So I would like to thank you for it. So, as my previous speakers have mentioned, that if they've done a perfect pre-op evaluation, chosen the right lens, the best lens possible, done a thorough biometry, given options of recorrections if possible. But in spite of all this, there are a lot of times when patients are still unhappy. It's like when they say I do not see anything, we say I also cannot see anything. It's just that condition. So what to do in this situation? We, of course, this has been done before, but again we have to start again from detailed history taking and slit lamp examinations. A lot of times patients have forgotten to tell us something, and we don't know what to do. Again, take a thorough history, especially of any systemic allergy, systemic illness, any previous eye disease, or what is the systemic condition. It's very important to take the history once again, and try to do a squint evaluation. In elderly patients, if it's not thoroughly visible, we probably wouldn't even think of doing a squint evaluation. So do a thorough squint evaluation, even if it looks like orthophoric. Whenever you're dealing with a happy surgery, a happy unhappy patient, after the detailed history, you will go to check the tear film. You can do a dry evaluation, but more than dry evaluation, in this kind of patients, you would like to see the T butt. And if you have any other dry eye tool, you would like to see that. This is just an example of a OCAS image. If you can see this dot, this is the OSI, the ocular scatter index. Sharper it is, better the quality of vision it is, and more it spreads, it means the quality of vision is poor. So this information you can get from a simple T-butt, or seeing if there are a lot of meibomian secretions present on the ocular surface. That means a patient has a ocular surface disorder, and in elderly patients you'll see a lot of it. It is a sign of subclinical inflammation, and post surgery it will just aggravate. Pre surgery it will not be there, but post surgery it can just aggravate. Intra parameters, or if not kept properly, also it can aggravate. And that's why the patients will have a poor quality of vision. So that's why you see the tear film to begin with. If you have a meibographer, please try to do a meibography, because meibomian gland dysfunction or dry disease is one of the most leading cause of unhappy cataract surgery patients. It's like chupta hai, khuchta hai. That all are the major complaints you see in these dry eye patients. And when you do a meibography, you'll definitely find that there are some abnormal glands present. You do not need to have a meibographer in your practice. Even if you have an autorefractometer, it's an infrared light principle. You just invert your lids, and you can see the meibomian gland health, and if required you can treat it. Why? Because if the meibomian gland health is also abnormal, it can have a poor quality of vision post surgery, which will be aggravated, and patients might have a higher discomfort. And the third is the epithelium. Now, you've not touched the epithelium in cataract surgery, but you've definitely made a wound, and post refractive surgery, there is going to be some amount of epithelial remodeling. So that is why it's very important. If you do not see anything, if your dry eye is also normal, if your topographies are also normal, patient is plano, but the quality of vision is poor, try to get an epithelial map done. I'll tell you why. Because we look at the topography to decide whether to go ahead with the surgery or not. But this is just an example, similar looking topographies, but pre surgery, the patient had an irregular epithelium. We do not need to check it for all patients. And we went ahead and did a cataract surgery. Post surgery, patient's epithelium remodeling was aggressive, it was not optimal, and he landed up in a cylinder of minus 1.17. He was not accepting the cylinder because it was coming from the epithelium and not from the other optical zone. So that is why whenever the patient is unhappy, poor cataract surgery which is aggravated, please, and if you can't find anything, try to get an epithelial mapping done, because abnormal epithelium can also be a cause of poor quality of vision, glare halos, and discomfort, and like glary vision. So that is why it's important to see that as well. Topography, of course, we do not need to do it for all our refractive surgery, cataract surgery patients before surgery. But if it's a normal patient, if it's a normal patient where you've done a monofocal lens, you do not need to do it, and your biometer will not tell you what it is. But post surgery, for any reasons, patient is unhappy, try to get a topography done, because keratometry is always can be normal, but there can be subtle signs of keratoconus or something underlying, which can also have a poor optical quality and poor quality of vision post surgery. That is why I also do a topography post if the patient is unhappy, to rule the same out. The second would be the pupil size and aberration. My previous speakers have, of course, spoken about it very well. But again, if the tear film quality is bad, or if the healing has not happened properly, post surgery patients can have higher order aberrations on the cornea. You can get it from any machines you have. Your normal topographer will also give you information on the higher order aberrations. And higher order aberrations being on the higher side, more than zero point 0.5, can also be a reason of poor quality of vision. So rule that out as well. Angles. Now, angles here, I'm not talking about the gonioscopy angles and the glaucoma ones, but if you have a perfect tear film, if you have a perfect topography, if you have done a perfect biometry, a perfect surgery, but the patient is still unhappy, what is the missing link? What is this, like, what is missing in this puzzle? This is just a eye trace basic of how your pupil centration and how the centration of the optical the light is, and this is the center of the limbus, this is the center of the visual axis, and this is the center of pupil. They should be aligned together. But if the angular distance between the visual axis and the pupillary axis, which is known as angle kappa, and the angular distance between the optical axis and the visual axis, which is known as angle alpha, are abnormal, more than 0.5, then also the patient post surgery can have a poor quality of vision. Everything is normal, but if these optical visual axis, pupillary axis, and optical axis are not in alignment, then also they can have an unfavorable outcome and poor quality of vision. So rule that out as well. And this is just one of the examples. This is a normal angle alpha, large angle alpha. Post surgery, even though the IOL is well centered, patient will be unhappy. And last but not the least, a lot of times, um, a premium IOL patient, I'm not talking about monofocal IOL patient, but premium IOL patient, especially the EDOF lenses and the multifocal lenses, we have explained them about the neuroadaptation time. But still, sometimes beyond the neuroadaptation time, also they come and complain to us that I have constant glare, halos, and the symptoms are not going away at all. The lens is well centered, everything is fine, but still the patients have complained. These patients are above 40 years, they have lost their accommodation, natural accommodation, but still they have some muscles in them which can lead to divergence or convergence insufficiency or excess, and that's when also the patients can have glare and halos. So it's very important for us to do a orthoptic evaluation when you have ruled out everything but you cannot find the answer. And if there is an orthoptic imbalance which is present, then you treat the patients with orthoptic exercises, and believe me, the patients do quite well because the neuroadaptation increases quite a lot. So that is why it's extremely important to rule that out as well. And nonetheless, everything done, sorted out, ruled out, if the patient still are unhappy, of course the answer lies in personality. Patients might not tell that okay, they have a personality issue, but you can always it's a freely available questionnaire, icing personality questionnaire. Just ask them to fill the questionnaire, and it will give you information whether the personality is normal or abnormal. If the patient is melancholic or choleric, that means it's a red flag sign, it's an abnormal personality. They are aggressive, restless, anxious, and always dissatisfied. So you cannot do anything in it. Very nicely, you can take the family in confidence, and you can refer to them to a psychologist for a counseling and see if you can improve that or not, because that is not your surgery, that's just their mindset. So a very easy way to rule out is a personality questionnaire, because they will not tell them that I have a problem. So you need a proof, right? So this is the way. So just to summarize, rule out any dry eye issues, rule out any epithelial related issues when your patient is unhappy, rule out any suspect topographies, the angles, and if nonetheless, if nothing works, rule out the orthoptics and the personality related issues. Thank you.
Thank you very much, Dr. Pooja, for making it such a elaborate of every aspects of surgery or of unhappy patients. We got this session a little late, but we tried to finish in time. Thank you so much for everyone. I think the next one are waiting for us.